So this is a case of a 63-year-old patient that actually had presented to our lab for atrial fibrillation ablation. We used a combination of the AcQMap along with TactiCat. So here we show the transseptal puncture with the help of the AcQCross to kind of give you a preview of this. We had gone in and we did a pulmonary vein isolation using the TactiCat ablation catheter, and then we introduced the AcQMap catheter that has the 48 ultrasound electrodes, as well as the electrodes for the mapping purposes. You have seen this from Tim Betts and Pope's presentation yesterday. The AcQMap catheter can very rapidly create, using the ultrasound technology, the shell. It's relatively stable and very reproducible. A little bit of a patient motion or impedance changes typically does not impact the contours of the map. So that is one of the advantages that you would have in this. As you quickly counterclock and move the catheter all around the left atrium, it creates a very rapid map within a few seconds. And it kind of gives you a nice outline of the atrial chamber, and then be able to see that. So that little green ball right in the center of the atrium is kind of your reference point, so that when you're doing single beat mapping, you can park your AcQMap catheter right at that. Kind of helps you to visualize so that your map is centered. Here we have the map in the left atrium. I mean, these are what we call the areas of interest, where you see the dynamic map showing areas of conduction slowing. And when you go back and look at this, oftentimes you find that these are the areas where you have heterogeneous conduction, and voltage is also heterogeneous. You may oftentimes find mixed score in these regions. I mean, we don't really know what it means by this, but obviously there is something to it. But oftentimes when you target these areas, you find atrial fibrillation terminating. It may not happen consistently. And then there are other times where you see there is heterogeneous score in this. Occasionally I have come across areas of micro reentry in these areas. Whether functionally speaking, if these are also related to the functional patterns of the atrial myocardial fibers is also something to keep in mind. So at this point, I'm showing you how we do what we call a super map. A super map is a non-contact map by rapidly moving your ablation catheter, not the ablation catheter, the AcQMap catheter all around the atrium. You don't touch the atrium, but the advantage is obviously with a single beat map, you're looking at the arrhythmia from a 10,000 foot standpoint. With the super map, you're getting a lot more detail, much more closer to the area where the arrhythmia is happening, either it's a focal tachycardia or a reentrant tachycardia. You're moving your catheter all around and getting a quick view whereby even multiple tachycardias, like oftentimes you see atrial tachycardias evolving from one morphology to the other, from one cycle length to the other. You can simultaneously bin these things separately, and then the system would be able to spit out these different type of tachycardias that you end up mapping in those 2 or 3 minutes that you spend in mapping this. So if somebody has 2, 3 different type of atrial tachycardias that continue to morph into each other, this is an excellent way to really identify those tachycardias and then be able to visualize them individually and target your ablation lesion set based on what you see. What would have typically taken many minutes and sometimes hours to map these, and oftentimes they're so unstable that you can't really map them in a consistent fashion using conventional electron atomic mapping systems. that particular problem can be very easily overcome with the AcQMap SuperMap. I mean, it literally took me about 2-3 minutes to really create the SuperMap. Once you have more than 80% of your atrial chamber covered, you have your data, and then your mapper can basically clean up the data for you and clearly showcase where exactly your atrial tachycardia is coming from, and then you can go after it and target that. So this is an example of sinus rhythm, SuperMap sinus rhythm. That's exactly what we did before. You see a nice activation across the Bachman bundle, conduction spreading across the posterior wall and the anterior walls, and then the veins were already isolated, so you see a line of block along the pulmonary veins. And then I also find it extremely helpful, especially once you get done with your anatomic lesion sets, like doing the pulmonary vein isolation. And then when you challenge the patient with high dose isoproterenol, and then you're trying to identify the focal triggers, non-pulmonary venous focal triggers, the single shot 3D maps are extremely useful. Like in this particular case, we put the catheter back at the center of it for a single beat observation, and patient gets on isoproterenol, and so there is a PAC that was localized on the proximal CS. Look at the big white circle on the right side of the screen where you see the earliest breakout that correlates to the electrograms. So this is one nice way of rapidly visualizing where your ectopic activity is coming from. You can see a similar thing with the PAC coming from the left atrial appendage. Try to focus on the white circle on the left side. You have an earliest breakout coming from the left atrial appendage. You can identify those and target those. And then next you will see a PAC coming across from the anterior wall, anteroseptal region. Focus on the white circle on the right side of the screen. You see an early breakout of a PAC from the septum. So in this fashion, you would be able to identify either a short-lived or a very consistent, repeatedly firing ectopic activity relatively quickly. The limitation of most of these non-contact mapping systems is not to have a contact map. So I think the AcQMap system has overcome that limitation. This is a contact map using the spiral catheter. You would be able to create a very nice map of the left atrium. And what you see here is this is a post-PVI left atrial map. The fidelity of the map is very good, and you can clearly see the clean voltage on the posterior wall, anterior wall, and I mean, this is pretty similar to what you would typically come across in any kind of map. So this would be extremely helpful to do your standard anatomic lesion sets and then have the map fidelity that resembles the normal cardiac anatomy. You don't visualize it as a blob, but you have much cleaner, nicer anatomic delineation. And there are times where you can even identify the gap. So in this particular case, you will see along the anteroseptal region a small gap around the right superior pulmonary vein that the contact map was able to showcase. So you can go to that particular spot, touch it up, ablate it, and then you'll see a remap of the same thing where you're able to get rid of the extra connections or the reconnections of the pulmonary veins. Again, a pretty nifty way of getting both the contact as well as the non-contact data, serving the different needs that you have. Again, you're not limited by the system's inability to do a particular function. More robust, gives you many more details and things that you really want to get across through the case a lot faster and quicker, targeting different aspects of the substrates that you want to go after. So this is a nice summary example of the contact map of the left atrium after the pulmonary vein isolation was done. In this particular case, we did not do much more. We didn't target the posterior wall since this was an early persistent atrial fibrillation. So we pulled to the right, and what you see here is right atrial AcQMap. Again, you take the AcQMap catheter, move it around into the SVC, right atrial cavity, IVC. It gives you a very nice quick iteration of right atrium. In this particular patient had a known history of atrial flutter, so we went ahead and did a Planar Ablation on this patient using the Tactiflex catheter. And interesting thing about this was our bilateral conduction times after the ablation were only 120. We started off at 80, we went to 120, and then we could not go any beyond 120. I mean, often when you have posterior corridor conduction, sometimes you would see your conduction times may not reach your maximum length, so you can see the nice conduction block there. So this is a second case we did on the same day where I want to show some triggers that are coming from the anterior aspects of the mitral valve, the early breakout on isopro on the septal portion. Sort of gives you a nice roadmap that when you have these non-PV triggers, you can target those and go after those. So in that particular case, we were able to do some cluster lesions along the areas where we found these PACs, and then be able to target those and get rid of those non-PV triggers. And it's this is the sinus map. It's showing normal activation, and then the so-called regions of interest where you see interesting activity. So the PVIs with non-contact mapping system gives you a good charge density versus bipolar voltage. You can appreciate the unipolar morphologies, and gives you the flexibility to really do many things. Like this is an example where we could show the isolation. So you clearly see once the pulmonary veins are isolated, you really don't have any activity going through. Reconfirmation of effective isolation in these cases. So to summarize, in a de novo persistent AFib, we could map the rhythm. In AF, in sinus, you could map the PACs. And we created 18 maps, and the whole procedure, including anesthesia, was less than 3 hours. So I find this very helpful when you have to target many different things. So I'll stop at that, and we can answer any questions if there are any.
Thank you, DJ, for a very nice presentation. So tell us a little bit about the system. When do you use it in your lab? What kind of cases? What differentiated from other mapping systems that you currently have available?
I mean, I have started using it more and more for my persistent AFib cases where I know that I will have to deal with not only the pulmonary vein isolation, which is more of a standard lesion set that we do for everybody now. When there is concern of multiple reentrant tachycardias with really large atria, where you anticipate there would be significant amounts of scar tissue, and you know that you're going to deal with multiple reentrant tachycardias, and where you would like to target the non-PV triggers to really create a comprehensive lesion set for improved outcomes. So I use this in combination with the TactiCat ablation system. The other advantage is it's an open system, so you can plug and play other types of catheters that you want to use. So that's where I find its clinical utility more and more. I think there's a lot more to be learned about what it means from these areas of interest that these non-contact maps show. Whether empiric targeting of these lesions results in improved outcomes, I think the Uncover AF basically showed us some initial promise. There is, I think, a Uncover AF2 study that will be up and running soon to really incorporate all the new concepts that we learned, whether it is mapping the focal arrhythmias and the rapid super map of reentrant atrial tachycardias that are relatively unstable and not long-lived, targeting those areas. And then how does this really fit into the overall strategy of scar homogenization? I think those are all things that could be easily studied with the help of this new system.
DJ, how stable are these maps? So you showed us some maps where you have some form of repetitive activities. So let's say you repeat the map in half an hour. Would you see the same?
They're very stable. I think the beauty of the system is the outer shell that's created by the non-contact map system is with the help of the ultrasound probes, and with the volume changes. For example, say you started the case and it lasted for about 3 hours. Say by the time the volume changed, the impedance changed, and a typical map would be completely skewed. But in this case, you can really flip around and create a new map very, very quickly. Like in less than 2 minutes, you get a new map, and you have a pretty stable deal. So because of the ultrasound-based shell creation, the maps are a lot more stable than conventional systems.
I'm talking, I didn't mean much as the anatomy, I meant the electrical findings, those repetitive, whether you're going to call them
stable. Actually, they're pretty reproducible.
So if you see something here and then you map after 10 minutes and it's not there anymore, what do you make about ablating that area if that area is now behaving normally? Is there still any use in ablating such a transient phenomena, or do you think there's something?
I think those areas of interest where you see these repetitive rotation movements, what it means, whether you should ablate or not, I really don't know if we know much about it, because these so-called areas of interest, I mean, sometimes they are linked to a scar nearby. Sometimes they are standard anatomic locations where you don't really find any voltage issues. So I really don't know if we know a whole lot about what it means to target them in terms of the overall impact on arrhythmia freedom outcomes.
Yeah. Andrea just joined us. Andrea, thank you for the nice case you did. I have a question for you regarding the case that DJ did earlier. I don't know if you have had a chance to see it. He closed with ablation. And I know you do both in your lab. You do coil ablation and you do, not coil ablation, coil closure and RF ablation for those leaks. What do you think work for what? When do you choose a coil versus ablation, or can you elaborate on that?
Yeah, right now it's more operator preference. So Ronnie still does most of his with coiling, and I do all mine with RF. We had a couple of cases where Ronnie used the RF after coiling to kind of seal a smaller leak left over. So I think it's operator preference. We discuss about comparing this in a formal study, but we haven't really started. I think, to be honest, it's going to end up, they're both effective. I think it's going to become a operator preference based on what they are comfortable. So I think for us, CP, RF, it makes a lot of sense because we're comfortable. The one thing that, I don't know if DJ mentioned that, the one thing we have to figure it out a little better is how we do a better job in targeting the leak. And right now, I think if you have intracardiac echo on the left, that help a lot, because the TE is not necessarily, unless you use 3D. If you use 3D, it's a little better, but 2D TE is not really very helpful. So that's really where we still have to learn a little bit. But I think it's going to become a preference, an operator preference decision. They are both effective strategy. I think RF is easier for us because we are used to that. Maybe less easier for an interventionalist, which instead, I think they technically they probably like more the coiling. I think that's the way it's going to be for a while.
We're waiting for Miguel to join us. He can talk, so we can have a few questions for the vein ablations that he showed. Meanwhile, I will ask Andrea about, you talked a lot about the power setting you use in the left atrium. Yes. Do you do anything different when you ablate in the coronary sinus, or when you when you're isolating the left atrial appendage?
No, very much the same. The only difference in the appendage, very low contact force. We also look at the impedance. If we have high impedance, we try to change, because it could be a pocket where you are more likely to get stim pop. So, but the power setting is the same, 45, at least 45, 47 watts. In the CS, we use 45 maximum. The difference is that in the CS, we move, and this has to be rigid. We move every 5 seconds. Unless we are really pushing against the atrium, where sometimes we stay a little longer. But if you are in the free wall, you have to make sure that you're not wedged, so you're not in a branch or stuck somewhere where you can have a stim pop. And then every 5 seconds you need to move. Otherwise, this is the way we've been doing to avoid the complication. We never really had a single case of coronary artery problem, but we really make an effort to move every 5 seconds when we are free floating. So the only time where sometimes we spend a little more, but a little more is never more than 10 seconds, is when the catheter is really pushed against the atrial wall. So we're really far away from coronary artery vessels. But otherwise, it's a rule to move every 5 seconds. We keep the power the same. Not 47, we stay at 40, 45, but we less. I know that a lot of people do 20, 25, 30. We had tried that at the beginning. We're more conservative, and we saw already with 45. We still see about actually the CS has more reconnection than the appendage right now. We just one of the researchers in our group just look at this data. So despite using 45, we still have probably about a 30% reconnection. When we used to use less than that, we have way more. Unless you do long lesion. But if you do long lesion, you still have the same risk of transferring the energy to the coronary artery. So the 5 seconds is really mostly driven to avoid that we do anything to the coronary artery.
DJ, I have a question for you. DJ, I don't know if you can hear me.
DJ, do you hear us?
Yes.
Okay, good. The issue is with your non-pulmonary vein trigger mapping. Yes. That you're doing with non-contact mapping. How much experience have you had with it? Is it very reliable? People tend to shy away from non-pulmonary vein trigger mapping because it can be complex. I mean, we use 2 multipolar catheters to try to use it at them as an antenna to regionalize and then more precisely map it. But what kind of experience do you have?
Yeah, we're working with that, to be honest. We're kind of more working to validate the system before we actually trust them. So I don't have a yes or no answer yet. We just started working with the basket to look at trigger. The one area we're focusing now is the right atrium, because the right atrium we feel is where we have more problem, unless they come from the CS ostium or the low crista where we have some recording. Otherwise, it's kind of maybe because of the shape of the right atrium. It's a little bit more complicated. So we're focusing on the right atrium. So we have patients where we know that they have trigger from the right because the left has nothing. But we're trying to validate the technology by doing some pacing and asking the system, where is this coming from? And we know the answer, obviously. So we're still at that stage, to be honest. So I don't have an absolute answer right yet. I would love if it works, because that's an area where I think will help this approach. It will help us with the right atrium, because that's where we struggle still a little bit. But it will help the field to have a tool that I think help people that are not necessarily comfortable with what you are doing now with the multiple electrodes.
DJ, can I ask you a question? Can you hear me, DJ? If you look at the issue about global chamber mapping versus up close and personal with the magnifying, usually with contact multi-electrode mapping, obviously if you concentrate on one, you can miss the big picture and vice versa. And the main area that we're having difficulty with is still scar. I know how to look at activation during scar, and non-contact tends not to do very well in the scar tissue due to the reduced signal to noise ratio. But my question to you is, now that you've used a system which provides both, has your faith in rotational activation patterns changed? And beyond the technical aspects of one mapping system versus another, have you found that with the advent and introduction to your lab of different mapping systems, that your belief in certain hypotheses about the electrophysiology of AFib has changed? Stuff that you previously would have said, nah, they're only ghosts, I don't believe it, or whatever. And now do you have any more faith in things, or do you dismiss things you previously believed in?
So, I mean, again, in all honesty, I mean, it's kind of a change in how I started looking at the dynamic electrical data with the rotational maps. When it matches with, say, a regional scar, or there is a little bit of a micro reentrant phenomena in those areas, it makes sense. And there are times where you actually find these sort of patterns of rotational, consistent, repetitive rotational activity, which doesn't correlate with anything underlying on a voltage map. And what does that mean? I still struggle with that. I don't know if we really understand this enough to say that it means something in every particular case. And I don't know if we really understand this enough to say that consistently targeting these areas will change the substrate enough that would translate into improved outcomes. I don't know what the others think about it. Andrea and Frank, what are your thoughts on it?
I agree to exactly what you said. I think we need to make an effort to validate this. I think what we have seen so far is not very encouraging when it comes down. It seems that with most of the stuff we work so far, it's a software produced phenomenon that is not relevant, to be honest. I think Shiv did a lot of work with some of the mapping system. They have done some bench work that is totally against rotational activity. And they're very smart basic scientists at UCLA. So, beyond what my personal experience has been in the past, I trust Shiv because I think he's very honest and he has good people. So, as some of these sort of pseudo mapping system that show this sort of ongoing phenomenon, I think we need to find a way to validate. I think I still see a lot of people that blindly trust what they see and just ablate there. And there will be a case where something happened. Just statistically, does that mean that that's the answer? I think you need to be sort of. I still feel we need to be open-minded and try. So I think it's good to try, but try with making an effort to validate what you're doing. To have this sort of blind approach is not going to help it in the long term to move the field, because we've seen many examples of this in the recent past.
So enthusiasm, right, to determine whether there is an answer or a clue that we can target, but not necessarily firm belief that we're there yet.
And I have a comment on that. As we kind of combine these different modalities, and we now have the advantage of combining contact, non-contact simultaneously, correlated with SCAR or any other things, I think we made some significant advance in our understanding towards it. We all know that there is something to it, but what is it and how does it really play mechanistically? I think is still to be understood. And I'm liking to see the connections a lot better than what we used to do before, without having to spend a lot of time on these things. So I think we'll get there. The next the Uncover AF2 would probably be a good opportunity for us to answer some of these questions in a more solid way, as many people get involved.
And to be fair, both myself and DJ encourage the company to develop further their content, which we know work, and actually they've been very responsive to that. So I think, so at least we have a fallback option that we all know how to use, and then we can sort of verify the dynamic mapping component of the system. And I have to say that it has been a positive experience to work with them, because they sometimes you talk to people that they just want to, they want to look somebody that just say what they like. I think they've been very responsive and very open to work with people that might, see things in a different way than their original product. So that's been a positive experience.